The Building Bridges, Our Future Together Symposium has been a celebration in honor of the inauguration of Hofstra's 9th president, Dr. Susan Poser. Special thanks to Dr. Poser and Dr. Lanahan, our interim provost, for joining us this afternoon. My name is Holly Syrup, and I have the pleasure of serving as the Dean of the School of Health Professions and Human Services. We are honored that our event is on the eve of the official inauguration ceremony for Dr. Poser. As one of Hofstra's newest schools, we too know what it's like to be a newer entity on campus. Founded in 2012, the School of Health Professions and Human Services has seen great growth in our enrollment, faculty research, and the number of academic programs that have been offered. But our mission is clear: to educate the next generation of highly effective, well-trained, and compassionate healthcare professionals who advocate for and promote health equity across the lifespan. And health equity is grounded in an understanding of the social and political determinants of health. The challenges of healthcare and healthcare delivery systems were brought to the forefront of national and international attention during the COVID-19 pandemic. And as we continue to battle the coronavirus, our efforts must focus not only on defeating the virus, but also on its impact due to the inequities and disparities faced by far too many of our community members and our neighbors. Our hope today is that today's program not only gets us thinking about health equity, but also serves as a call to action on this very important topic. We are delighted to have Mr. Daniel Dawes, Executive Director of the Satcher Health Leadership Institute at the Morehouse School of Medicine, as our session's keynote. Mr. Dawes will be followed by Dr. Corinne Kyriacou and Dr. Andrea Nerlich, two outstanding scholars and faculty members from the School of Health Professions and Human Services. After our speakers, we will open it up for questions that I hope will also lead to a lively discussion. Let me begin by formally introducing our speakers. Dr. Andrea Nirlish is an associate professor and program director for the Rehabilitation Counseling Program. She serves as editor of the Vocational Evaluation and Work Adjustment Association and serves on their national board of directors. She has presented at the national, state, and local levels on topics related to rehabilitation counseling and education. Her research interests includes transition services for students with disabilities, ecological assessments and vocational evaluation, collaboration models, social justice and advocacy, and student and professional development and identity. Dr. Nerlich holds a PhD from Michigan State University, as well as an MA and BS from Springfield College in Massachusetts. Dr. Corinne Kyriacou was the founding director of Hofstra's Master of Public Health program and currently serves as the associate professor and chair of the departments of Population Health and Allied Health and Kinesiology, and was named the 2013 HPHS Teacher of the Year. Dr. Kyriacou's current research focuses on identifying best practices for establishing time banks, which are programs that build community by connecting neighbors in the exchange of needed services and skills. Dr. Kyriacou has published and presented on public health topics, including hospital to nursing home transitions, consumer-directed care, integrated care for the elderly, managed home care, and the importance of experiential training for health professionals. She received a doctorate in social policy and health service research from the Heller School at Brandeis University, where she was an Agency for Healthcare Research and Quality Fellow. And she holds a master's in public health degree from New York Medical College. Prior to joining the Hofstra faculty in 2004, Dr. Kyriacou spent 5 years as the Director of Research at the Metropolitan Jewish Health System, a continuum of care provider of services for the elderly and chronically ill based in Brooklyn. And now it's my pleasure to introduce our keynote speaker. I have to say that he has quite the bio, so I've had to modify it just a little bit, but you're going to love it. Mr. Daniel Dawes is a widely respected scholar, researcher, educator, and leader in the health equity, health reform, and mental health movements. He is also the co-founder of the Health Equity Leadership and Exchange Network, which is a nationwide network of over 2,000 governmental and non-governmental leaders, researchers, and scholars, focused on bolstering leadership and the exchange of research, information, and solutions to advance the evidence-based health equity-focused policies and programs. Among his many achievements, he was an instrumental figure in shaping and enacting many federal policies, including the Mental Health Parity Act, the Genetic Information Non-Discrimination Act, the Americans with Disabilities Amendment Act, and the Affordable Care Act. Mr. Dawes' research focuses on the determinants of health inequities among under-resourced, vulnerable, and marginalized communities, and is the pioneer of new approach to examining inequities, including the political determinants of health. Mr. Dawes currently leads several major health equity projects in the United States, including several intended to mitigate the impact of COVID-19 on communities of color. Mr. Dawes is an elected fellow at the New York Academy of Medicine and serves on several boards, commissions, councils on improving health outcomes and elevating health equity in the United States and around the world. He is the recipient of several national awards and recognitions, including the American Public Health Association's Award for Significant Contributions to Public Health, the American Psychological Association's Exceptional Leadership and Advocacy Award, the Centers for Disease Control and Prevention's Health Equity Champion Award, just to name a few. Mr. Dawes' work focuses on addressing the systemic barriers that prevent the U.S. from becoming what it could be, among the healthiest nations in the world. It is now my distinct pleasure to welcome Mr. Dawes to the podium to provide his keynote address.
Well, good afternoon, everyone. Good afternoon. I know we can do better than that. Good afternoon. All right. Dr. Aarp, let me thank you so much for that very generous and kind introduction, and to thank all of you for allowing me the opportunity to give these remarks today. I am especially excited to join you because of one person in particular who is very near and dear to my heart. That is your new president. For those of you who don't know, she actually was my teacher a few years ago, not that long ago, right? She was my torts and ethics professor, and I've told her this morning when we had breakfast that her fingerprints are really all over the accomplishments that we've achieved in health policy over the last 15 years, from the Obama administration until today. And it was through her class that some of the ideas that we had when we were working on the Affordable Care Act, those 62 health equity provisions, really are a result of the time spent in her classroom and what she taught us. So thank you, President Poser. It is wonderful to be here, and it's wonderful to be with you all today. I thought since this is a School of Health Professions and Human Services, that we would do a healthy activity. Is that okay with you all? Yes? All right. So I've gotten permission from our president. We don't need a release form. And we're going to take a field trip today, and we're going to go to Peconic Park. Anybody's ever been to Peconic? Raise your hands. Anybody? What? We're in Long Island and nobody's been. Okay, good. Well, that actually helps me because now you don't really know what's there. So I'm going to ask you to use your imaginations with me for a little bit. Imagine with me, okay? We're going to actually have President Poser take us. She'll be our leader because I've never been either. But we're going to follow Susan Poser, Dr. Poser, to Peconic Park. So Dr. Poser's taking us. Imagine we're following her. We're going through Hempstead Highway. Am I saying that right? What's that? The Turnpike. Okay, we're going through Hempstead Turnpike. There you go. See why she's leading us? And we get to Peconic Park. And Dr. Poser finds us a really nice spot right by a beautiful river. Didn't know they had a beautiful river there, did you? Yep, beautiful river. And she says, I think this is a good spot. So thank God we came prepared. We have our bags full of all sorts of equipment, our camping gear, and we settled down by the river. And not even 2 minutes go by, and all of a sudden we hear, help, help, I'm drowning. And we're shocked, we're frightened. What is happening? So Dean Syrup, the strongest swimmer among us, says, oh my God, we've got to save this precious soul. So she jumps into the river and she swims towards the person to this young woman, and she pulls her to shore. She saves her. Let's give Dean Syrup a hand, please. Woo! And my gosh, 30 seconds maybe, max, goes by, and we hear again, "Help, help, I'm drowning." And we say, "Oh my God, what's going on?" And she says, "Oh, I gotta go again, we gotta save this soul." So she jumps in, and she pulls this guy to shore. By this time, you can imagine she's what? She's tired. Oh my gosh. It's exhausting saving lives, right? So, let me see, who am I gonna pick on next? So now I have, let's go with Dean Porcelli, right? Dean Porcelli says, "I have this really good idea. We're seeing these people coming out of nowhere. They keep coming downstream. What the world? Let's go further up and see, what's happening." Now, I've been told I don't have my mask, so I can't really venture up like I wanted to. But imagine we're going further up, right? And Dean Porcelli says, wait, is that right? What am I seeing? We see people clinging onto some rocks that are jutting out of the water. They're hanging on for dear life. And we say, oh my goodness, what? What can we do to save them, right? Thankfully, we did come prepared. We have our life jackets. Some of us brought some ropes and other equipment, and we start throwing it to the folks who are clinging to the rocks. And we say, "Here, grab on." And we all work in sync, and we're pulling them to shore, right? Give Dean Porcelli a hand, please. And then at that point, we have Marjorie Hilaire. Where's Marjorie? All right, Marjorie. So Marjorie says, "You know what? I'm seeing a little pattern here. Let me take us a little further upstream." We say, "Marjorie, that's a really good idea." And Kevin Bunk, where's Kevin? All right, Kevin. Kevin says, "You know what? Yeah, I think that's a really good idea." So together they're leading us now further than we've ever ventured in Peconic Park. Well, we've never ventured there, but anyway, you get the drift. So we go to this amazing place. There's this huge cliff. And we see what's been happening all along. We see folks who've been going right to the edge of the cliff. You heard curiosity kill the cat, right? And they're looking and they're saying, "Wow, look how beautiful this is." And whoops, they fall over the cliff into the water. And we see that again and again. We think, oh my gosh, so this is what's been happening, right? As we ventured further upstream, we've gotten to the source of the problem. Well, we decide to climb up this cliff to see what's really resulting in this stuff. And we have Dr. Edward Caulfield and Darren Brownlee. Where are you? Where are you guys? All right, there you go. Woo! So they say, we've got some solutions. Let's figure this out. They say, well, it looks like we're going to need some warning signs. We need to put up a little fence area to keep the folks from going too far in. They come with all sorts of ideas, brainstorming with all of us now, right? Because we're all in this together. We're going to come up with the solutions. And little by little, we step back, and we're observing. And what do we see? Less people falling over the cliff of health inequities, right? So what does this story really mean? So first of all, thank you both, our professors, our alum. Woo! What does this mean? Well, it means that for too long we've been venturing downstream, right? Taking care of people one at a time, trying to save them from sudden death and despair. But it hasn't been working. We've ventured up midstream now. A lot of us are in the social determinants of health movement. And we've been working, right, at this community level, working to address some of those mid-level issues that are impacting our communities. But we have not gone to the instigator, the causes of these health inequities in the United States. And so today, I want to take us there as we address the political determinants of health. So I have a lot to cover, as you can imagine, and your dean has been very gracious in allowing me the extra time that I need. But let's begin. So in her inaugural poem, the past National Youth Poet Laureate, Amanda Gorman, reminds us, among countless soul-piercing refrains, that being American is more than the pride we inherit. Didn't you love that? More than the pride we inherit. It's the past we stepped into and how we repair it. To move beyond merely nibbling around the edges of the problem of racial injustices and health inequities in this country, we really have to effect more, meaningful and effective solutions. And so I want to really push us to think about how we first have to look back and dig a little bit deeper to uncover these inequities and injustices, examine how they were concretized in our structures, our systems, and communities over time, and address the laws and the policies, at all levels, that have basically propped them up. So today we're going to look at how we can repair the past and advance health equity and health justice by understanding and leveraging these pesky political determinants of health. And, they say that a picture is worth 1,000 words. So I want to start with a short video, which I hope is going to be worth way more than that, called Jessica's Story. Jessica's Story highlights the compounded effects of political determinants of health in driving these inequities and injustices among our most marginalized and under-resourced communities. So, Dean Porcelli.
To best grasp the political determinants of health, let's examine a hypothetical example. It combines experiences of real people in urban and rural communities. Imagine a 19-year-old woman, we'll call her Jessica. After enduring several miscarriages, she barely survives giving birth to an infant 9 weeks early, the baby weighing only 3 pounds. Her son is placed in the neonatal intensive care unit, the blood from his umbilical cord revealing over 200 toxins. Where did the system fail Jessica and her baby? How and why did these results occur? 3 years earlier, Jessica had left her parents' house. Access to treatment for her dad's substance use disorder had been eliminated when policymakers closed 3 of the city's public community health centers to save money. Contending with his wife's lack of education, neither of Jessica's parents could secure a job with a livable wage, prompting serious and substantial mental health conditions. Jessica moved to a low-income neighborhood in the city. She never knew of the extent of how the appalling conditions of her neighborhood were politically determined. For example, determined to keep housing segregation in place, politicians expended very few resources to build sidewalks, parks, or recreational facilities. Healthcare providers refused to operate in Jessica's community due to poor reimbursement rates for Medicaid. Because they resisted creating bus routes, lawmakers dissuaded grocery stores from operating in the community, preventing residents access to fresh fruit, vegetables, and meat. Simultaneously, policymakers altered zoning laws to permit development of a dump site and a chemical plant, switching the community's water source from a clean river 10 miles away to a nearby polluted river to save money. This water was used to drink, bathe, and wash clothes. It also irrigated the lawn at Jessica's apartment building, adding to the list of pollutants and environmental hazards in her neighborhood. And because her district lacked established tenant rights, her landlord had no interest in improving unhealthy housing practices. Jessica found work as a cashier at the corner convenience store, a job with no employee benefits, including health or disability insurance. Because policymakers rejected proposals to increase minimum wage to a livable income, Jessica often substituted her employer's free snacks policy as a meal, never realizing the effect that high-fat, high-sodium food would eventually have on her or her baby's health. With local politicians striking down an effort to ban smoking in convenience stores, Jessica was constantly subjected to a barrage of secondhand smoke. And when she discovered she was pregnant, no attempt at receiving health insurance coverage was successful. Her non-ACA compliant plan denied her maternity coverage because they viewed her pregnancy as a pre-existing condition. Medicaid, the government's health insurance program for low-income families, denied her coverage for not being poor enough. After finding a ride to the free clinic, Jessica waited more than half a day to be seen by a second-rate physician, a doctor who was condescending and offensive. Realizing she could not afford to take more days off from work, she never went back. At 31 weeks, a neighbor drove Jessica to a hospital ER 20 miles away. Seeing that Jessica was experiencing excessive swelling in her face and ankles, as well as seizures, the emergency team decided to deliver her premature son immediately. Due to complications, her newborn son was sent to the neonatal intensive care unit. Once his organs were deemed mature enough, he was taken off the machines and sent home with severe cognitive defects. And in their apartment, Jessica and the baby were exposed to mildew and cockroaches, causing her son to develop respiratory problems. The landlord refused to remedy the poor conditions, telling her to move if she didn't like it there. Jessica struggled to find early childhood care and access to schools with educational assistance, healthy food options, and other resources needed to thrive. Because their school and community lacked the resources to enable Jessica's son to even barely reach his potential, he dropped out of school after entering 8th grade, just as his grandmother had done, repeating what is surely the ongoing rule of poverty. Jessica's story shows the compounding effect of political determinants over personal responsibility. No matter how reliably Jessica tried to act, structural, institutional, interpersonal, and interpersonal obstacles stood in her way. Political determinants were pulling strings that prevented Jessica and her family from achieving optimal health and their full potential. What does this mean for all of us? What can we do to improve and mend our community's most damaged systems?
Well, we know from Jessica's story that racial and ethnic minority communities, people with disabilities, lower socioeconomic status white communities, and LGBTQ plus individuals, among others, die prematurely in this country. And the toll that it's taking is certainly unconscionable. But the one thing, if you don't remember anything else that we talked about today, the one thing that we must always remember is that in our country, the nation's health is not an organic outcome. It is not a coincidence that certain groups of Americans have been experiencing higher premature death rates, poorer health outcomes than others. But why? So why has this been happening? Well, today we recognize in public health and in healthcare that there are a variety of forces that collectively impact our health and determine the quality and the extent of our lives that we will have on this earth. They include, of course, the social determinants of health. So let me go to the next slide. It's not working. How do I do this? I guess I can just do it on this. All right, I'll just do that. Okay. So these include the social determinants of health, the environmental determinants, the economic, behavioral health, healthcare, and genetics, right? And of course, you can see on your screen that researchers have given a relative weight to the impact that these determinants have on us. But when you think about it, right, it is true, that key among these determinants they have found really play an outsized role in these human-made pre-existing inequities. These are the social determinants of health. These structural conditions in which we are born in, we live in, and we eventually die in, that affect all dynamics of health. But key among and underlying each one of these determinants is a political determinant that we cannot ignore. Too often, you see, we've been stopping at the social drivers of inequities, failing, as I mentioned earlier, to look back and dig deeper to really see the depths of the problem and understand the root causes. And as a result, we've been missing the link between the social determinants and these other determinants and their political roots. So think about it this way. For every social determinant of health, there was a preceding legal, regulatory, or ordinance or other policy that really created these structural conditions that we find ourselves in. I thought I'd illustrate this with another story, right? You can tell I love stories. So I'm going to illustrate this again with another river story. Imagine with me, if you will, if we had all of society sitting on the banks of a mighty river. We're fishing. We're finding nourishment in the resources that the river provides. The health inequities that we face are represented by the caliber or the differences in the caliber of fish and the quantity of fish we encounter. You see, some people have a bounty of healthy fish and vegetation to feed off of, while others may only have small fish, no vegetation, or malnourished fish. Different people having access to different types of resources and different parts of the river represents the social determinants of health, okay? Now, some people are located in a slower moving part of the river by no fault of their own. Others are located in more lush parts of the river and benefit because of such by specific decisions that have been made on their behalf. These are the political determinants of health. Somewhere upstream, decisions were made to divert the river to benefit certain people and harm others. And decisions were made to place certain types of people on specific banks of the river while placing others elsewhere. These upstream decisions have downstream impacts. You see, we're living in a quadruple pandemic, as you can imagine. I'm not only talking about COVID-19, I'm talking about the social and racial reckoning, the mental health crisis, the economic crisis that so many people in our country are experiencing right now. And so this quadruple pandemic or syndemic really illustrates the inconvenient and harsh truth about the impact of these determinants of health and how collectively they impact, significantly contribute to our society's health inequities. As you saw from Jessica's story, it really does show the compounding effect of political determinants over personal responsibility. Because no matter how hard many of these individuals, African Americans, Native Americans, Native Hawaiians, Latinx Americans, Pacific Islander Americans, and lower socioeconomic status individuals try to act responsibly, there are always structural and institutional and interpersonal and yes, even intrapersonal obstacles that have been hindering them. And you see beneath these communities, notice as we talked about in Jessica's story, are these political determinants that have pulled and continue to pull strings that prevent them from achieving their optimal health and full potential. And so is it any wonder then why COVID-19 has not been striking all groups equally? Is it? Well, no, not really when you think about it, because our economic and social policies have not been benefiting all groups equally. So I want to take us now back 400 years. I'm not going to take us to 1619, but I do want to take us to 1641, because during that year, as abolitionists were making headway in their efforts to show how evil this institution of slavery was, the business interests, or what I call the commercial determinants of health, got together and figured, well, my goodness, they're making some headway. In order to sustain our business model, we better get with these policymakers and legalize this institution. And so they worked for months in 1641 to create the Bodies of Liberties Law. This law was then used as a template for other colonies. So New York, second, Connecticut, others followed suit. And over time, they also amended this to include the offspring of these enslaved Black people. Interesting, right? Well, as if that were not enough to keep a group of Black as well as indigenous populations down, the policymakers, working with these business interests, decided to create additional laws that explicitly prohibited these groups, explicitly, Black and indigenous from being able to raise their own food, from earning their own money, from learning to read and write, from being educated, especially when it came to English. They were prohibited by law from moving within a certain mile radius. If you were enslaved, about a mile radius. If you were Black and indigenous, you had to have passes in order to move, or you had to, if it was in the evening time, carry a lantern to move about. What do we call these today? We identify these as part of the social determinants of health, but it was a law that instigated the results, right? And forbade them from being able to address their social determinants of health. Well, we saw these laws being recycled from one generation to the next, one century to the next, from the 1600s into the 1700s, then into the 1800s, where Jim Crow reared its ugly head with a vengeance. And we saw the proliferation again of laws that were intended to limit these population groups from being able to achieve health equity themselves, right? From being able to achieve their full health potential. Well, we go into the 1900s, and now you see the creativity of a lot of racist policymakers. Because now, again, these civil rights champions are making headway and saying, wait a second, these explicitly racist laws are unconstitutional. And the Supreme Court basically said, all right, fine, you got us. You no longer, policymakers, can do that. You can't deny these social and economic benefits to one group of individuals over another. That's illegal. So what do? They wise up and they say, well, let's craft these policies and make them to be facially neutral laws, right? Facially neutral policies. So they weren't explicitly racist on their face, but essentially once they were implemented and enforced, they had the same effect as the other facially discriminatory policies. And so I want to take us now into that history as we're looking at big P policy and little p policy, right? Governmental and non-governmental policy, and how that has worked over time to drive the results that we see today. So in the early 1900s, you know, after going through World War I, we had a crisis in this country under FDR. Franklin D. Roosevelt recognized that there were many folks who were literally malnourished. They were starving. There were folks who were losing their houses. It really was a disaster. But interestingly, during that time, the Franklin D. Roosevelt administration, working in concert with lawmakers in Congress, created a policy called the Homeowners Loan Corporation Act. And in this policy, they basically authorized property appraisers in over 200 cities in America to go into the neighborhoods of these cities and to grade them from an A, B, C, or D, align them with a color code. If you were A communities, you were green, the B communities were blue, your C communities were yellow, and your red communities were, or your D communities were red. And the A communities were your affluent white communities. Your B communities were your middle-class white communities. Your C communities were what they called undesirable immigrant communities. And lastly, the red communities were your predominantly African-American communities, and those were your what? They were classified as hazardous communities. So it took a law, right, authorizing the development of this study, which then, once the study had aggregated all of these reports, it was sent back to DC, to the federal government. They in turn used the policy to create additional policies, determining where to allocate home mortgage loans. If you were in these red and sometimes yellow communities, or yellow line communities, you were oftentimes denied VA home mortgage loans and FHA loans. So what did the federal government do? It again starved these Black and brown communities of the resources that they needed to not only survive, but thrive in our society. Well, after that, we go through another World War, World War II. And right after that, we have another crisis again, now a mental health crisis. And President Truman decided he was trying to work on health reform, but he couldn't get his supporters in Congress to push for access to health care by all population groups, right? There were Southern Democrats who were opposed to that effort. Well, What's interesting, though, is you also saw after that the proliferation of facially neutral laws again. So how many of you have been to Harlem? Anybody visited Harlem before? Yes? Okay, good. In many of these communities, you may have noticed, and especially predominantly African-American communities that were redlined, you may have noticed a major highway cutting right through these communities. If you're in the Midwest, you may have noticed these railroad tracks again, splitting the neighborhoods in half. Or you may have seen the disproportionate location in Harlem of bus depots, right? 6 of the 7 bus depots in Manhattan were placed in Harlem. And yet, is it any wonder through public health research that these Black and brown communities now are suffering from the highest rates of asthma? Well, not really, because they're breathing in the most polluted air, owing again to this transportation or the infrastructure that we just talked about. And those, again, were devised by acts of policy, right, that instigated these structural conditions. So we had the Highway Act that created the highway system, cutting right through their houses. We have the Housing Act that created the Urban Renewal Program that really decimated housing, both apartments and houses, for many African American and Latino communities, right? Basically displacing over 500,000 of these population groups. Well, after that, it really leads to the results that we see today. We can feel the effect. Through public health research, through epigenetic research, we know that inequality gets under our skin, and it does lead to accelerated aging, right? It leads to what? The acceleration of various chronic diseases. So I want to talk about that very quickly, because we know that the impact of slavery has been associated with long-term impacts on contemporary mortality, on poverty, heart disease, maternal and infant mortality. We know that through the research of these epigeneticists, they have been able to identify that Black women who have triple-negative breast cancer, they suffer from the worst kind of breast cancer, most deadly form, again, can be associated with the isms in our society: racism, sexism, classism, and again, owing to these political determinants. Well, what do we see now when we think about the impact of these policies in these communities? We know that we see basically this poverty tax now on these communities in the form of higher payments for auto insurance, home mortgage loans, lower property appraisals, again, creeping up even in this year of 2021. We see the deserts that have taken hold in these communities: food, pharmacy, and hospital deserts. I remember when Flint, Michigan, was going through its water crisis, and I visited there. That's the one place, the only place I have ever cried, because I couldn't believe it. When you talk about the social determinants, my God, the way that people had to, God forbid if they didn't have transportation, they couldn't even get to a grocery store. Nobody was operating in those areas, right? So we see these deserts. And now we see another phenomenon happening in these communities as we face another existential threat: climate change, through the impact of climate gentrification, where by law, many Black and brown individuals were forbidden to purchase properties by the seashore. As the sea levels rise, now we see a movement of folks on the seashore onto higher elevated lands, which, quite ironically, that's where Black and brown folks had to move to, right? They could not purchase the property by the seashore. They were moved onto higher elevated lands, and now they're being pushed out and displaced. Again, hundreds of thousands of folks. So all of this now compounding, creating the results that we see downstream. So let me talk about today what is going on. We have seen the impact. Sir Michael Marmot, Professor Michael Marmot at a UCLA in London, has stated that life expectancy as a measure of health tells us a great deal about how we're doing as a society. And the inequalities in that society tell us even more. So, where you live matters. Where you live matters. And as you can see, neighborhoods that were redlined or starved of resources by acts of law and policy are now today the communities that have the lowest life expectancies. So you could see Nassau County, where you all, almost 16-year difference. Suffolk County, nearly 20-year difference. We're talking about a generation between communities, and that to me is really unacceptable. Well, we've talked about how policy has been a driving force for many of the inequities that we observe in our communities today. But let me just say this, there is a playbook for how to correct this, for how to advance health equity and justice for these marginalized groups. Because I actually argue that only policy can fix what policy has created in the first place. So let's take a look now at this. So I'm going to take us back again in history, right? You could tell I love history. And I'm quoting William Faulkner, the great Southern writer. He says, "The past is never dead. It's not even past." How true is that, right? As we've been going through this very historic and dark time. So where are my Bob Marley fans? Any Bob Marley fans? Woo! All right, Bob Marley. So Bob Marley, another great thinker, says that in this great future, you can't what? You can't what? You can't forget your past. That's right. So we're going to go back to 1789. I had a wonderful stroll around your campus today. Got a little bit lost, and I ran into Benjamin Franklin. Any of you ever ran into him? Yeah? So Benjamin Franklin greeted me, and I thought, oh, this is interesting because you're in my story today. So I'm going to take us back for the sake of time. I'm not going to be able to look at the mental health reformers or universal health reformers, but I want to focus my attention on the minority health reformers. It's an interesting piece of history. So back in 1789, for all my history and political science buffs, you might recall that's when our constitutional republic was established. And at that time, you had a group of mental health reformers, abolitionists, and advocates for homeless individuals, among others, who came together and said, you know what? We need to really strategize here and get this federal government of ours to provide for the general welfare of our most vulnerable people. And they decided, after a while, that, you know what? We need a policy influencer. So they thought about it and said, you know what? Benjamin Franklin, why not approach him and see if he'll lend his name to this cause? And although Benjamin Franklin had been a lifelong slave owner, and yes, he had used his newspapers to allow the abolitionists to advertise their cause and whatnot, and yes, he prevented Thomas Jefferson from putting a piece in the Declaration of Independence blaming the King of England and preventing them from really getting legislation to abolish it, so the story goes. Benjamin Franklin said, yes, I will lend my name to the cause. I will sign this petition that you have created. In that petition, these health equity champions, if you will, pleaded with the federal government to stop the separation of children from their mothers, to stop to really, prevent the breakup of these families, to stop this evil institution of slavery. They also advocated in there for access to medical care, health care services to these vulnerable groups, not only black, but poor whites at the time, as well as other population groups that were residing in the country. And they asked for education to be provided, for true employment opportunities, for food and other necessities of life, clothing, etc. And they sent it to the House, to the Congress, sent it to the House and Senate. And if you think that we're having a very contentious debate during this really interesting period of our history, it seems to me from the records that it was equally troubling as well. Folks in the House and Senate responded. It stirred up a contentious debate. They said, the Senate said, we're not even going to dignify this petition with an answer. They ignored Benjamin Franklin. But the House said, we can't let him get away with this. And so in bullet by bullet, the House made the argument why they could not stop the separation of these children from their mothers, why they couldn't stop the breakup of these families, enslaved families, why they couldn't provide for the necessities and others. And so they made basically a confederalism argument. Their argument was, well, you know what, it's really not, we're not authorized by the Constitution to provide for the general welfare of these people. That's best left to the states who are closest to the people, the people in their jurisdiction. So they should be the ones to deal with those matters. They punted it. Interestingly enough, though, right, which is always, when I take that equity lens to the law, interestingly, not even 8 years later, Congress was able to ignore that argument when they wanted to implement a policy that would benefit who? white male sailors, right? To provide health care for them, health insurance coverage. Well, to make a long story short, it would take 75 years after that attempt by Benjamin Franklin and the abolitionists before the stars would again align, this time during a major civil war. Under the leadership of President Abraham Lincoln, I was glad to see a bust of him in your library, Abraham Lincoln and his supporters, the radical Republicans, got together and they said, now is the time to not only abolish slavery, but to provide all of these necessities of life. So everything that these equity champions had fought for in 1789 and 1790, they again took that playbook and they said, now is the time for us to enact it. And the first time now in US history, we had a major federal bill addressing all of these social determinants of health that impacted newly freed people as well as poor whites who were displaced as a result of the Civil War. But there was one provision in particular that was so contentious, not even President Lincoln could retain it in the bill. What do you think that provision was? Anybody know? Any guesses? Anybody remember Obamacare, those debates? Well, it was the provision to provide medical care. They were okay, these policymakers were okay with what? Providing education, providing even security, providing food and clothing and employment opportunities. But they were not okay with providing health care that would lengthen the lives and help to bolster the health of these newly freed and poor white populations. And so after 2 years of negotiating, as the Civil War was winding down, President Lincoln says, I'm going to compromise and I'm going to strike that from the bill. Let's get it done. Let's sign it into law. So they did. They struck it from the bill, the Freedmen's Bureau Act. He signs it into law. And guess what? We have the first major federal policy addressing the social determinants of health. But as we have seen in this time, racism does not sleep. Hate doesn't take a break. And we saw the forces at work to undermine that law. Not 4 weeks after he had signed the bill into law, President Lincoln was assassinated. And his supporters basically said, you know what? Upon reading this law, we believe that it does authorize us to provide health care services to these newly freed people and to poor whites. And so they went about establishing sanitariums, clinics, and other healthcare facilities to help bolster healthcare access in this country. But as you heard me mention, those opponents of health equity and health reform fought for 7 years and finally succeeded in dismantling America's first major health reform law, first law addressing the social determinants of health. Again, after that, it would take us, what, 150 years to realize America's next most comprehensive and inclusive and equity-focused health law, the Affordable Care Act, or Obamacare. So for the sake of time now, as I wind down, let's talk about how we can leverage the political determinants of health. What are they? Well, here's my definition and ensuing model of the political determinants of health. I define it as, the system, as involving the systematic process of 1, structuring relationships, 2, distributing resources, and 3, administering power. And they operate simultaneously in ways that mutually reinforce or influence one another to shape opportunities that will either what? Advance or hinder health equity. So how has this worked? We talked about redlining through the Homeowners Loan Corporation Act, right? One way of structuring relationships. But there are a host of other laws and policies that are still on the books today. The anti-miscegenation laws that were designed to prevent blacks and whites from mixing. The blood quantum requirement laws that were designed to keep indigenous populations, Native Americans, from mixing with the other population groups. We had immigration laws steeped in racist ideology, policies for those of you who work with children with disabilities, policies that were developed from preventing these groups from receiving an education in schools or accessing housing in communities across the country. We also have this notion of federally recognized versus non-federally recognized tribes, an issue that we have been dealing with during this terrible pandemic, where the federal government was not giving resources to the non-federally recognized tribes. And the list goes on. When we think about the distribution of resources in this country, is it any wonder, as I mentioned, why we see the inequities? Well, there's a dearth of policies, a dearth of resources and appropriations going to ensure that these communities have access to various programs, health services, special education, home and community-based services, social services, you name it. Initially, for those of us who are health equity champions, we were raising our hands saying, listen, if the people who are being most negatively impacted right now are essential workers, right? Although we tend to look at them as expendable workers, well, we need the COVID testing kits. We need vaccinations. And we were pushing for the equitable distribution of these critical resources, but again, ignored, right? Think about the administration of power now. This is always the more controversial piece of the PDOH. You're talking about redistricting, gerrymandering, including restricting ballot access, voter suppression tactics that many of us in the South are experiencing right now. Purging voter rolls of irregular voters, minimizing opportunities for early voting, closing or moving polling places. We see these tactics used again and again, right? It's not surprising. And collectively now, they have come and worked in tandem to create the conditions that we see downstream. So this is my wonky model, my best attempt taking the evidence from a legal lens, political science, public health, and historical lens to figure out what are the levers that have been pushed and pulled based on the evidence that have worked to either hinder health equity or to advance this bold agenda. So the idea here, for the sake of time, is that once a perceived health inequity is identified, you must conduct your due diligence to ascertain whether the health outcome that you are observing is what? Systemic, avoidable, and unjust. How far can you venture upstream, right, to understand whether it is an institutional or structural barrier that created or is perpetuating or is exacerbating the inequity? What is the policy change desired? And can you demonstrate the value of investing in change? So in the United States, one thing I want you to always remember, advocates must understand the disquieting and harsh truth that the political determinants of health inequities have rarely been addressed unless their reduction or elimination served other purposes. So what are those, right? The success really depends on how palatable they are to commercial interests and whether you can align that with a government investment value. What's in it for the government? What is the economic argument or the national security argument that you can raise? These are lessons that we had to learn very quickly in order to negotiate and advance the Affordable Care Act over the finish line. So, you know, I will share, if you're interested later on, exactly how that's worked with the mental health reformers for those of you who are mental health champions, which really is my number one passion. But for the sake of time, let me close by saying, where do we go from here, right? So we've looked at how the foundation of our system fuel inequities, right? How the political determinants of health inequities continue to ravage through our marginalized and underserved communities, and how they lend racism, sexism, classism, homophobia a helping hand. So where do we go from there or from here? Well, before I close, let me bring this notion up. I want to take a moment to push back on this common refrain that I've been hearing about or reading about, right? This idea that, or this desire to return to normalcy. But to be blunt about it, there absolutely cannot be a return to normalcy. Normalcy failed us, and it will fail us again. Normalcy, before COVID-19, left marginalized communities without the resources they needed to survive and thrive, and without the data to tell their stories. We absolutely cannot ignore the tough lessons we have learned so far by attempting to return to a pre-COVID-19 mindset. The inequitable landscape before COVID-19 was just as dire as it is today, which means we have an opportunity to act right now. Normalcy is not equity and justice. Equity and justice should really be our only option moving forward. So here are 5 things that I want to leave you with as I close my remarks. 5 things that we can do to elevate health equity in America. You know, I hope you haven't lost hope in listening to these remarks, because it can be depressing to learn how long it's taken us to advance this health equity agenda in America. But the good news is that these structural inequities really aren't permanent. They're not permanent. That's the good news. But it's going to take collective action and agreement from all of us, from all of you, committed to advancing the cause of health equity in your communities and in our larger society to really stomp these inequities out. So first thing, what can we do? We have to engage in the very tough conversations and advocate for a full commitment to tackling health inequities upstream in all areas. We've got to have these tough conversations around race, place, and class. We have to. We have to work upstream further than we have been willing to address the social and the political determinants of health inequities. We must understand when they are at play. It really does matter. Third, we have to research the history of our communities. We are such a transient society, and we can easily move into a neighborhood and make judgments about the people who have been living in there. We've got to address the past policies and programs at all levels, international, as well as national, state, and local, that created, have been perpetuating and exacerbating these inequities. Because in our country, exclusion in policy has always been easier to realize than inclusion, basically. We need to do a better job realizing that the people who are closest to the pain, closest to the problem of health inequities, should be the ones, leading, driving these solutions. We need to do a better job working in tandem with them to effect these changes. And then lastly, we have to understand that health equity begins, and it's going to end with the political determinants of health. Let me just thank you all again for the privilege of your time, for this opportunity, for becoming part of the struggle, essentially, right? To advance health equity for your future patients and the individuals living in your communities who you will serve over time. I thank you all. I thank you, Dean Syrup. I thank you, of course, President Poser, and to Dean Tony Porcelli and others for really exercising bold leadership and allowing these conversations to occur, and for helping to develop the solutions that will move that needle further, of health equity, that needle further than we have been able to realize in this country. Again, thank you all so much for your time.
Good afternoon, everyone. What a week it's been, truly a celebration of how Hofstra has been working to build bridges to the community in the pursuit of a more just world. I'm honored to join the many faculty and guests who have provided a glimpse into the exciting work they're doing, and thank you so much, Mr. Dawes, for your remarks, your thought-provoking remarks. Really incredible work that you're doing. So public health professionals work to assure the conditions in which people live, learn, work, and play, and make sure that they're healthy. And to do this, we have to actively promote policies and systems and services that enable good health and seek to remove obstacles and systemic and structural barriers that we've just been hearing about, such as poverty and racism, gender discrimination, age discrimination, and other forms of oppression that have resulted in health inequities. So today I'll talk a bit about how we can build health equity through some emerging age-friendly initiatives. Population aging is one of the biggest social transformations of the 21st century. Over the next 30 years, the proportion of the world's population over 60 will double from 12% to 22%, and is expected to total 2.1 billion in 2050. We're also living longer. By 2050, it's expected that there will be over 400 million people over the age of 80 worldwide, and more people are living to be 100. Here in the US, approximately 45 million Americans are age 65 and over, and by 2030, in just less than 10 years, that number will reach 75 million Americans. At that point, 1 in 5 Americans will be older than 65. By 2034, the United States will, for the first time, be a country comprised of more older adults than children. Furthermore, the demographic patterns of US society have become dramatically more diverse. 1 in 5 older adults in this country is a person of color, and in 20 years, that number will grow to 1 in 3. We are at a critical crossroads. Society needs to prepare for the challenges and the opportunities that these demographic shifts portend. While doing so, we need to consider how policies and practices in both health and non-health sectors impact health and health equity. Social determinants of health-related factors that you've been hearing about, such as access to healthy food, employment, stable income, safe and affordable housing, safe neighborhoods, reliable transportation, and social connectedness, have significant implications for older adults' health, wellness, and quality of life, and their ability to live independently and age in place. Racism and ageism are also pervasive social determinants of health, clearly embedded in political determinants, and together they interact to exact a particularly devastating impact. Because of systemic racism, many Black and brown older Americans enter their later years with the highest rates of poverty, the lowest incomes, and the most severe health disparities of all older people in this country. The age-friendly approach, which is rapidly spreading across sectors, is one that strengthens participation for and representation of underrepresented groups, and thereby produces more equitable outcomes in health through the focus on social determinants of health. Age-friendly initiatives, at their core, seek to build health equity. In response to global population aging and rapid urbanization, the World Health Organization established the Global Network for Age-Friendly Cities and Communities in 2006. This initiative focuses on action at the local level that fosters the full participation of older people in community life and promotes healthy and active aging. Membership in the network is not an accreditation. Rather, it reflects a commitment of communities to listen to the needs of the aging population, assess and monitor their age friendliness, and work collaboratively with older people and across sectors to create age-friendly physical and social environments. Membership is also a commitment to share experiences, achievements, and lessons learned. An age-friendly community is a barrier-free community designed for diversity, inclusivity, and cohesiveness. Age-friendly environments enable people to stay active, connected, and able to contribute to the economic, social, and cultural life in their community. They seek to foster solidarity among generations within communities, facilitating social relationships and bonds between residents of all ages and backgrounds, reaching out to older people at risk of social isolation through personalized efforts designed to minimize economic, linguistic, or cultural barriers. At present, there are over 1,000 cities and communities in 44 countries that are members of the WHO network, all working to improve the lives of millions worldwide. The American Association of Retired Persons network of age-friendly states and communities was established in April 2012 as an independent affiliate of the WHO Global Network. In the United States, there are now 573 communities part of AARP's network. This number was just updated yesterday, adding 2 more communities since I pulled this graphic earlier this week. And membership in this AARP network means that a community's elected leadership has made a commitment to actively work with residents and local advocates to make their town, city, county, or state age-friendly. Age-friendly New York City was launched in fall of 2007. In December of 2017, New York enrolled in the AARP network and became the first state in the nation to do so, and there are now 7 states enrolled. Several communities on Long Island and members of this network, including the city of Glen Cove and both Nassau and Suffolk counties. Hofstra students and faculty are involved with the efforts in Glen Cove and in Nassau County. The AARP age-friendly framework rests on 8 domains of livability that you can see here that address disparities that impact people of color, members of the LGBTQ community, low-income households, and other underserved groups. The age-friendly model itself seeks to amplify the voices, concerns, needs, and wishes of vulnerable or overlooked populations. Community practices include disaggregating data to understand the needs of low-income seniors and then targeting resources to them, ensuring that programming is accessible, culturally relevant, and translated if needed, and partnering with others to build relationships, trust, and greater impact. The model also seeks to empower families, caregivers, and local communities to support older adults where they live, as this is where most people want to experience aging. Ultimately, people of all ages benefit from the adoption of policies and programs that make neighborhoods walkable, feature transportation options, enable access to key services, provide opportunities to participate in community activities, support housing that's affordable and adaptable, and enhance neighborhood cohesiveness and social engagement. And as people are living longer and healthier lives, they're increasingly interested in working past the traditional retirement age. Evidence shows that older workers bring many advantages to employers. Diversity, including age diversity, can bring perspective and widen the team's skill set and customer knowledge. Increased loyalty, trainability, and extensive experience all adds up to value. However, older workers are a talent pool that is frequently underutilized because of misperceptions and stereotypes. Given the demographics discussed earlier, companies that fail to adjust to this will be at a competitive disadvantage. So the Age-Friendly Institute's Certified Age-Friendly Employer Program seeks to change this, and it recognizes organizations that are committed to being good places for older people to work. As of June 2021, there were approximately 100 employers that have now earned Certified Age-Friendly Employer designation, including Aetna, the American Heart Association, AT&T, CVS, Fresh Market, Mass General Hospital, to name a few. And these workplaces receive this designation because they're investing in training across all ages of employees. They're offering flexible work arrangements. They're including age and diversity policies, removing age identifiers from applications, and encouraging reciprocal mentoring so that younger people and older people can learn from each other. If this emergent trend is to have an impact on health equity, it will need to take root in all kinds of workplaces and be intentional in its efforts to be inclusive. Health systems are also working to become more age-friendly. The Age-Friendly Health Systems Initiative at the Institute for Healthcare Improvement, in partnership with the Hartford Foundation and the American Hospital Association and Catholic Health Association, sets standards for better care of older adults. The standards focus on 4 evidence-based contributors to high-quality, cost-effective care, which are known as the 4 M's: what matters, medication, mentation, and mobility, focusing always on the ultimate goal of making sure that what matters most to older patients is what's driving the care plan. By documenting the racial and ethnic breakdown of their patients, age-friendly health systems are analyzing health outcomes stratified by race and ethnicity, allowing them to take follow-up actions as needed to address disparities. By explicitly linking the rigorous collection of racial and ethnic data to quality measures and accountability, the Age-Friendly Initiative is taking a big step forward with the potential for improving care well beyond the immediate goal of measuring and improving access to the 4 M's. Today, more than 1,000 care settings, including hospitals, clinics, nursing homes, have joined this initiative, including Northwell Health. Shifting demographics is also spurring the reimagination of higher education. With unprecedented numbers of adults living longer, many want or need to learn and earn longer too. A new life stage is being recognized, one that exists between the initial career, family building years, and then the years of frailty associated with old age. Most people in their 60s and 70s and 80s are healthy, energetic, and often surprised to be pushed into retirement or laid off with few job prospects. While some may want to move into full leisure mode, the vast majority seek new pursuits, whether paid or unpaid, that offer meaning and purpose. But they find few roadmaps and few options for lifelong learning at universities. The reality represents a lost opportunity for all parties, older adults and younger ones, universities, and the society at large. By focusing on only young people, universities pass up a chance to add a new source of revenue, diversify and enrich campus life and learning, and leave a bigger mark on the future. Age-Friendly University, the Age-Friendly University Initiative offers a set of guiding principles institutions can use to assess the extent of which their programs and policies are age-inclusive, as well as to identify gaps and new opportunities. Unlike conventional continuing education programs, which tend to offer age-segregated enrichment courses for retirees, new age-friendly initiatives, university initiatives, are establishing multi-generational learning with social impact work, bringing younger and older students together in classes that address issues like inequality, climate change, global health, and social justice. Many age-friendly universities are taking an even more innovative approach that extends beyond intergenerational learning into housing, creating lifelong learning communities. These models have the potential to solve many of the challenges mentioned previously, while enabling universities to capitalize on idle real estate. On-campus housing occupancy has been declining across higher ed for many years, and Hofstra is no exception. NYU has just recently launched an intergenerational housing program to promote housing and economic security among graduate students and older adults, thereby reducing social isolation and fostering cross-generational cohesion. The program, which reflects the university's efforts over the past 5 years to bolster college affordability and prioritize equity and aging, intentionally recruits first-generation students, racial and ethnic minorities, women, and individuals who live alone to share housing. At Hunter, they're launching an intergenerational housing initiative where low-income older neighbors in Harlem, New York, rent space in their apartments to graduate students. Washington University in St. Louis places students studying counseling in their own apartments within a campus-based assisted living facility, and students forego paying rent in exchange for organizing social activities for older adults. A new retirement community trend is emerging. University-based retirement communities provide assisted living, taking advantage of the variety of amenities and services available on college campuses, and the intergenerational environment of college students, working professionals, and seniors. We've seen the number of retirement communities with connections to colleges and universities increasing. There are over 80 such programs today at places like Purdue, GW, LaSalle, Notre Dame, University of Michigan, Arizona State, to name a few. Evidence shows that the 3 most successful strategies for building equity among older adults are policy change, education, and intergenerational contact. Evidence also speaks to the power of lifelong learning and meaningful social interaction on health and health equity. So age-friendly universities can help society achieve health equity goals for older adults while also transforming themselves. So in conclusion, rather than segregating older members of society from their communities, rather than discounting the wisdom and experience, rather than stereotyping health and social preferences, rather than underestimating older adults' potential and capacity for growth, we need to embrace our success at extending lives, healthy lives, through intentional redesign of policies, programs, and infrastructures. We have both a responsibility and an opportunity to reimagine our communities, our workplaces, our health systems, and our universities to be more age-friendly. And in doing so, we should always use the health equity lens, but let's keep our eye on the ball that Mr. Dawes talked about, and that is to strive for the social justice, to remove those barriers, those upstream barriers. We need to address racism, bias, discrimination, and other systemic barriers across all sectors of society. And I think the age-friendly paradigm offers a way to do that. Thank you.
Hello. I'm Andrea Nerlich. I'm the director of the Rehabilitation Counseling Program here, and I did title this Considering Disability in Health Equity and Justice for All, but I could just call it Ditto after so much of what Mr. Dawes shared. For those who can benefit from a visual description, I am a white woman in my mid-40s, my hair in a bun, my eyes have glasses on, I have black pants and a top and a gray jacket, and I have some black shoes on that make me feel tall. Okay? So I really want to thank my 2 co-presenters for really situating a lot of the health equity talk today. But I also, I was part of a panel yesterday that looked at disability. And so I really, while, we are experts, and while we had expert panelists on that, there were two speakers from the class of 23 at Hofstra. And so Bree Hall and Sanjita Bhattacharya, they are both women with disabilities, and I really would implore you to go to the recording of their session so that you can really center their voices. But I'm here from an allyship perspective, so I really want to talk to that. And as a rehab counselor, because we have a lot of our hands in a lot of vocational work and we prep people for interviews, we always say when you have that question like what's your weakness or what's a problem you've had, you spend less time framing the problem and more time framing the solution. So that's what I'm here to do today. So a couple of questions here to really start the talk. What is disability? And I'm going to use disability as an umbrella term here because sometimes, in my field of rehab counseling, we think of everything under the disability umbrella. So we do situate mental health, we do situate substance use, we do situate health conditions under there. Sometimes people with those conditions or situations don't situate themselves with the disability community, but I'm going to use it as an umbrella term. And I do use that intentionally because it really focuses on the medical model. And you see here that there's diagnosis and labels that are attached here to the medical model. And I'm not anti-medicine, I'm not anti-diagnosis. It's great because it allows us to select evidence-based practices. It allows us to have insurance reimbursement. However, unfortunately, a lot of times it situates the main focus of the problem in the person, okay, rather than the things around them. It really segregates people with disabilities by labels. And by doing that, they don't come together as a force to be reckoned with. They are allowed to remain separated and segregated. And as professionals too, I think it keeps us siloed, okay? Because we say, this is my specialty, that's your specialty, and we don't really come together. And I really am wanting to see much more of that, okay? Also, who has a disability, okay? This is great, numbers are great, numbers are provocative. And by looking at the numbers, it allows us to drive research, it allows us to show justification for policy changes, it allows us to go for funding. I can tell you without looking at any of these numbers that disability is ubiquitous, okay? And, as I, was speaking with a colleague earlier, I didn't want to burst her bubble, but disability happens to be the only open access, equal opportunity minority group. If you're not part of it, you will likely be one day if you live long enough. And as we see with healthy aging, we are going to be. So we have to get out of the mindset of kind of the us and them. And we also see with the pandemic that marginalized communities were impacted and are now part of the disability community. But numbers only speak to the magnitude and not the solution. So I think a better question for this is, what's the disabled experience? Okay, and I intentionally, again, I guess I have a lot of intentionality in my life, used red and green here. Typically we look at the red, okay, when we think about disability. We look at the negative parts of it. We look at the negative attributes. We also use these things to contribute to the negative perceptions and devaluation of people with disabilities. Now, we could use this to frame our response and our solutions to what we want to do, but I'd rather take the other side. We are strengths focused in rehab counseling. So looking at the green, if we think about the rewards, if we think about the ideals, the goals, the end in mind, I think back to being at my son's Meet the Teacher night in 4th grade a couple of weeks ago, and all of the class rules aren't listed as don't do this. It's listed at instead use this positive behavior. So if we focus on what's in the green and use that as a lens in order to conceive health equity for people with disabilities, that brings in a much different focus. So what are some of the mechanisms that we can use for action? So, I love the concept of the political determinants of health. In rehab counseling, we didn't really have this language around social determinants of health, and now I have a new lexicon, but oddly, my understanding of the social determinants of health actually bridged the political determinants of health, so we'll kind of see some of that. But thinking about lenses that we can use as mechanisms for action, I kind of came up with 3 here. First is anti-ableist. If you don't know what ableism is, it's discrimination against disability. It's the ideal that, being able-bodied or having typical performance is supreme and is superior, okay? But ableism is, again, fairly pervasive. Now, we may think of it in the big forms of someone parking in a handicap spot when they, in fact, do not need it, or there's no braille signage. We can also think about different types of microaggressions of seeing a person with a disability and saying, oh, you're so brave, okay? If you are unfamiliar with ableism, Maria R. Plasios, I hope I'm pronouncing her name right, wrote a wonderful poem called Naming Ableism. And she has a lot of examples of just the everyday experiences that we don't think about in the smaller A ableism. I also think that interprofessional collaboration, and that's why I appreciate HPHS, because we have so many professions in there that can work together for collaboration. But I like the model or the graphic that I chose. I didn't make it up. There's a lot of Googling going on for these graphics, but if you look at that, it doesn't speak to identities of a profession or names of a profession. It really speaks to the ingredients that you need, the values that you need for professional collaboration, and I think that that's a much stronger model for that. And then the last is advocacy. Being a counselor, we are so steeped in advocacy, and we have to stop thinking of advocacy as on behalf of, and think of it as with. Okay, not just on behalf of people with disabilities, but with people with disabilities. And what's great is that I understand as a counselor, and I look at other counseling professions and other related professions, I know that we all have the same ethical imperative to do this. But then as I went and looked at medical professions and public health professionals and whatnot, you have the same ethical imperative. So I think that that's another bridging point that we can find to work together on these issues. A couple of other frameworks that I think are helpful. Yes, the social determinants of health, okay? But I wanna really focus on some of those things that are beyond kind of healthcare and what we typically think of as only behavioral health or primary care health situations. In rehab, we've always had this, but we call it the psychosocial aspects of disability. So just a change in language is a really cool way to bridge perspectives and being able to work across specialty lines or discipline-specific lines. So looking at where people work, learn, eat, grow, live, and love is where I want to focus a lot of my action. And then the biopsychosocial model, or what we would call the sociopolitical model, this really does get more at the political determinants of health. Those of my students were probably ad nauseum know about the International Classification of Functioning, which is a way that we conceive of disability. Now, yes, that's used in medical settings and usually assigns a bunch of codes to it, but I want to look at it more to expand not just, what's in the person, but the communities they're in, the ways that they want to participate, the activities. Intersectionality, obviously brought to prominence by Kimberly Crenshaw, but really looking at intersectionality in terms of multiple marginalization and realizing that if we're going to enact policy, if we're going to create services, that we can't do it by cherry picking an identity we want to work with, that we have to look at that integration of what's going on in these multiple marginalizations and how we have a higher representation of disability, LGBTQ and BIPOC in communities of poverty and within that culture of poverty. Disability justice is a stem off of this. Disability rights, yes, we are probably familiar with that term. The disability justice movement is centered and founded by Black, brown, queer, disabled folk, okay? And the idea there is that even disability rights is centered on white privilege. And we need to really kind of change that paradigm to look at the multiple needs of folks. Trauma-informed care, for those of you that are familiar with counseling, is the moving from the mindset of asking what's wrong with you to what happened to you. There's some great resources from the CDC on how to address this, but understanding that many of the folks that we come in contact with and really looking at that case of Jessica, that I didn't really see a lot of big T trauma that experienced to her, but all these little T traumas, all these cumulative traumas that we have to understand that many of the marginalized communities that we're working with come in with baseline trauma, okay? Sometimes we refer to that as minority stress. And then universal design. The idea that our spaces should be equitable, flexible, intuitive to use, and multi-purpose, okay? That makes it more welcoming and it improves mental well-being and quality of life. So what could we target? I'm gonna talk about these 5 things here. 4 things. So with messaging and communication, you know, health messaging, the focus should be on that that you have the correct audience, you have the right information, that it's easy to understand. We have to understand that we cannot use one-size-fits-all models for any of this, especially when thinking about disabled populations. We have to make sure that we're disseminating information in multiple formats, whether that be foreign language formats, Braille, pictorial, and that it's in accessible means and media, whether that is closed caption, ASL, using alt text, okay? But we also have to understand that we can't rely too heavily on one main form of media. Everything can't be social media or on the internet or cable related, because again, that's linked to people with access and privilege and money. So if we're only relying on those media sources, we're kind of missing a bigger picture. We have to think about plain language. I'm not saying you dumb down language. I'm saying you make it in vernacular and words that are understandable to the communities you're trying to serve. We do that a lot, you know, in our field. We use so much jargon, so many acronyms, and I forget what the acronyms mean sometimes because we use them so often. But a lay person is not going to understand that. Tapping into the community to share the information. This top-down approach is difficult if you don't have stakeholders within the community that can take that top-down message and disseminate it and have it reach more people. And then if you take nothing else away from my talk, please take this away. Use the terms disability, use the terms disabled. Stop with the euphemisms. Stop with differently abled. Stop with special needs. Stop with physically challenged. These are disempowering and invalidating terms to the disability community, okay? And it really is just easier for us without disabilities because it distances us, it sounds nicer, and we don't have to talk about it, okay? Whereas people with disabilities, disabled folks want to talk about it. They want to have that recognized, excuse me, and have pride in that. Accessibility, please know that compliance is not accessibility. It's not a checklist. And, you know, one of the speakers yesterday was engaged in the ADA Amendment Acts, and he's a person who will say that there's a failure. We're not taking everything into account. We're not enacting it, and we're not enforcing it the ways that we should be. And also recognizing that all accessibility is not architectural. Okay, yes, this is great. We have to broaden our scope. We have to think about the ways, and I don't want to link it to disabilities or diagnoses, but thinking about sensory environments, overstimulation, noise. Is your event on a transportation accessible route? Is there a bathroom? What are the size of the chairs? Okay, this is a standard size chair and not everyone is going to fit it, and what does that mean? Incorporating universal design, like I said, the speakers yesterday, Bree and Sanjita, can speak more to that, but think about where you live. If you live on campus, go back to your dorm tonight and just think about all the places where you would get hung up based on what your disability was. When you're creating public events and mobilizations, activism, okay? People with disabilities want Black lives to matter. They want trans lives to matter. But if those events are not accessible to them, they can't engage in the community in the way that they want. Sins Invalid is an amazing group. It's an amazing disability justice group out of California. They have a disability justice primer called Skin, Tooth, and Bone that I highly recommend that you check out. And I actually have a lot of the resources at the end that I'll be able to share for that. Addressing attitudinal barriers, again, this is the most pervasive because attitudinal barriers will continue to exist even in the most physically accessible spaces. We want to make sure that we are not foisting onto people with disabilities the idea that they should be fixed or cured. Many people with disabilities will tell you that they need to have that. They want to have that identity. We have to think about the ways that our systems value or devalue life in terms of crisis decision-making, using things like daily adjusted life of years to determine who gets a ventilator and who doesn't get one. And then training our professionals. I have a number of easy-to-use resources, but Emily Ladow, who actually graduated from Adelphi University right down the street, just came out with an awesome book called Demystifying Disability, which is a very easy read on this topic. And then engaging and using the voice of people with disabilities. The mantra of the disability rights movement is nothing about us without us. But we sometimes, yes, can use our, professional social capital to be able to gain access to spaces, but once you gain the spotlight, get out of it, okay? And leave that place for people with disabilities. And when we're doing research, making sure we're using accessible techniques to do that. My vision for Hofstra is that there's a number of ways that we can create projects in which we can work together. These are just a number of them. If anything on this slide even tweaks your fancy a little, talk to me. Okay, there's a lot of folks in counseling and mental health professions that are doing work related to this. I know there are folks in our public health and our other programs that are doing it. We need to find ways to germinate and collaborate for our common social justice goals. And lastly, I will take my 30 seconds to say this. If you scan this QR code, it is an article that actually was of mine that was just published. And I had to laugh, and I did take a picture of one of your slides, Mr. Dawes, because the name of the article is Why Not the New Flexible? The Argument for Not Returning to Normal After COVID-19. And so if you scan that, it is published in an open access journal with my colleague, Dr. Tony Saya at San Diego State University, and my colleague, Dr. Sarah Johnston at Drake University, who's got me half convinced to get my MPH already. So thank you very much, and I hope you understood what I said. What did I do with my mouse? Oh, darn it.
Thank you all so much. We are just about out of time. Does anybody have a very quick question for the group? I know I'm standing between you, all of you, and dinner. So thank you all very much. I appreciate you coming. And please give one more big round of applause for our panelists. Thank you all so much.